Tudo ok, Alan.
Okay. Good morning, everyone. Thank you for watching our digital meeting on evidence-based photobiomodulation. My name is Alan. I'm a faculty member at Piracicaba Dental School, part of the University of Campinas in São Paulo State, Brazil. And today I'm really happy to introduce our international speaker. Mr. James Carroll is an engineer. He's also a fellow of the Royal Society of Medicine in the UK, the founder and CEO of THOR Photomedicine. Mr. Carroll is certainly one of the most important names in the medical field of photobiomodulation, and he has been promoting evidence-based photobiomodulation literally all over the world with recent lectures to the members of the United Nations and also to the members of the US Congress. Today, he will be talking about how to teach photobiomodulation in the medical and also in the dental settings, and also about evidence-based photobiomodulation protocols in the industry. James, thank you very much in anticipation for this great opportunity to have you in our dental school. It's really an honor for our group to have you here today. And so welcome and thank you for joining
thank you very much
today. Thank you for joining our group today. The floor is now yours.
Thank you. Bom dia is the limit of my Portuguese, apart from
fantastic.
And I hope Google Translate has done the right thing here for me.
It's fantastic.
There is much to teach. I was given 1 hour to introduce my training course, which is 8 hours long, and I'm going to speak for 30 or 40 minutes on how to teach photobiomodulation. So its mechanisms, show some of the evidence. We have to mention physics and dose, of course, safety, contraindications, precautions. It'd be nice to spend more time on how to treat. We will show some evidence-based treatments with photobiomodulation in dentistry at the end as well. Really, first, I think it is important when teaching a class to explain the curriculum, because there is a lot to learn. So these are the headings of each section of the training. People must have a context to understand what it is, where it has come from, how far it has got, where do we think it's going, and how does it do these things? What happens after light is absorbed in a cell? Then look at evidence from randomized controlled clinical trials. It also works on healthy people, not just on diseases. Then people want to learn how to treat patients, but they have to learn something about dose, first of all. And to understand dose, they have to learn some physics. And of course, with all medical trainings, you must talk about safety, contraindications, regulations, and reimbursement. Some of these things we do not have time to mention in any detail today, because I have like 30 minutes to explain all of this to you. So the quickest explanation about photobiomodulation is science fiction movies like Star Trek. On Star Trek, when somebody is injured and they go to the sick bay, the doctor gets out a laser, aims the laser at the injury, and the injury heals instantly. That is photobiomodulation. Any questions? Just kidding. So the effects of photobiomodulation are not as fast as in the TV and on the movies, but you get the idea. We shine light on people and they will heal more quickly. Unfortunately, this treatment has had many different names, not just this list here. I have found more than 100 different names for photobiomodulation. The leading name on PubMed and on the internet generally is low-level laser therapy, but it has now been agreed that a better name is photobiomodulation, partly because it does not have to be a laser in order to work. Okay, so it had many names. Now the world agrees photobiomodulation is the correct name for this treatment. So there's good evidence from many randomized controlled clinical trials for a wide range of applications. So most of the evidence is on musculoskeletal pain, like sprains and strains and creaky joints. There's about 200 randomized controlled clinical trials for these pathologies alone. There's also evidence for its effects on neuropathic pain, hard to heal wounds like venous ulcers and pressure sores and diabetic foot ulcers, breast cancer related lymphedema, difficult painful syndromes like fibromyalgia, chronic regional pain syndrome, post-surgical pain. This is like in dentistry, post-surgical pain, treating temporomandibular joint dysfunction, dentine hypersensitivity, aphthous ulcers. There's good evidence for the effects here, and I'll talk more about dentistry at the end. In cancer therapy side effects, so the leading application is oral mucositis, a side effect from high-dose chemotherapy or radiotherapy. I'm going to show you some data on this at the end as well. But also breast cancer-related lymphedema, as I mentioned, but also head and neck lymphedema, a dry mouth, a xerostomia, treating radiation dermatitis. We can reduce these symptoms in head and neck cancer patients. And also some effects on healthy people. What does it do for wellness, strength, endurance, recovery in athletes as well? I'll show you a tiny bit towards the end. You should show the technology if you want to teach this, that people have an idea about it before they try and learn the details. So I have our equipment, which is, I explain to people what the buttons do and what the different probes are for and the different handpieces, clusters of lasers and LEDs, and even an intraoral LED cluster probe treats the whole oral cavity in 1 minute. And how it's applied to the patient like this, sometimes intraoral, sometimes extraoral treatments, transcutaneous through the cheek, maybe treating a TMJ point, treating the mental nerve when trying to treat for neurosensory recovery after injury to the inferior alveolar nerve. People know that light has effects on the body. So this can be explained to them before they try and learn something new like photobiomodulation. Everybody knows, and every doctor knows that that we use sunlight to help. Well, when we go out in the sun, we change color. That's as a kind of photochemical effect. And we know that when we use sunlight to help synthesize vitamin D, that's another form of photochemistry. You may know that they use blue light on prematurely born babies to prevent neonatal jaundice, a form of photochemistry. You may know that dermatologists will use ultraviolet light for treating psoriasis and vitiligo. So nobody should be surprised if light has some other effects on the body. Now, low intensity lasers for photobiomodulation are not dangerous, but you must not put them in people's eyes. There's different classes of lasers. Some lasers are more dangerous than others. There's lasers in your life every day when you go to the supermarket and they use laser beams for reading the barcode, or maybe in lecture pointers, you know, and nobody gets hurt. Not all lasers are dangerous. The lasers that patients and your colleagues think about when they think of medicine are the class 4 lasers. These are the ones that have a thermal effect. For photobiomodulation, we mostly use class 3B lasers. They have no harmful effects on skin or clothing, but they are potentially hazardous to the eye. So you and your patients and any observers should be wearing laser safety glasses just to be safe, okay? So you must teach this thing to your class so people understand the kind of where it is on the scale of risk. We also use light emitting diodes, LEDs. They have some similar qualities to lasers, and we don't really have time today to explain the difference between them. Apart from LEDs are much safer. With LEDs, we can put them in the eye. This is no harmful effect from light emitting diodes. But I'm not going to do that with my laser. So the history is interesting and useful to understand PBM, but today we have no time to explain. You'll have to invite me back and I must do the whole course for you so you understand the full story about this. But it's worth understanding the progression, the discovery of the theories about the laser and the discovery of photobiomodulation. Then I like to explain to people that there's a lot of good evidence for this now. There's more than 700 randomized placebo-controlled clinical trial, more than 4,000 laboratory studies looking at the mechanism of action and the dose response. Last year, in 2020, there were more than 600 600 academic papers published on photobiomodulation, more than 7,000 in total. And with just our own products, we've delivered more than 30 million treatments so far. And some of the data is published in the world's most famous and respectable journals. The state of the art, in my view, is that the strong evidence is for musculoskeletal pain with 200 randomized controlled clinical trials, 47 randomized controlled clinical trials on oral mucositis for treating side effects of high-dose chemotherapy and radiotherapy, and also for treating athletes for improving strength, endurance, and recovery, more than 60 randomized controlled clinical trials. Less evidence, but still we need less cases, more randomized studies, more multi-centered studies. But it seems clear that it works on breast cancer-related lymphedema, hard-to-heal wounds, neuropathic pain I've mentioned already. But moving down, how about this? Treating the eye with light-emitting diodes, dry, age-related macular degeneration, the leading cause of blindness in the developed world, is responding well to this treatment. And now we're putting light in the brain. It's improving cognitive and emotional function in healthy people, but also early experiments seem to show it helps stroke patients, depression, post-traumatic stress disorder, traumatic brain injury, Alzheimer's and Parkinson's disease, treating acute heart attacks, reducing dependency on opioids for people with an addiction, and anecdotally, multiple sclerosis, Lyme disease, many interesting applications. Next thing people want to know, how can one medicine treat so many different diseases? Is it too good to be true? Well, it doesn't try to treat everything. It has one effect, and the effect is mostly on reactive oxygen species, what doctors call oxidative stress, what your patients might call free radicals. Where do they come from? They come from mitochondria. So I have to remind students about the effect of what the mitochondria does, and about glycolysis, and also about the Krebs cycle and the electron transport chain. So I do some revision so people understand how glycolysis makes a little bit of ATP and how it also makes pyruvate, which makes two more ATPs in the Krebs cycle, but also NADH and FADH2. And then you begin to learn how electrons are donated, and it pumps hydrogen ions across from the matrix through to the inner membrane so that it causes a proton gradient, which ultimately is what's going to drive ATP synthase by the time it gets over here. Now we're going to show how water comes along. It takes the electrons off the electron transport chain, more hydrogen ions drive ATP synthase and makes ATP. And we get lots of ATP from the electron transport chain. And that is the story for healthy mitochondria that most people learn. Very simplified. Then I have to explain that when cells are stressed, they behave different from when they're normally. Let's imagine this is a mitochondria. We have hundreds and thousands in every single cell of the body. And I'm showing here the terminal enzyme with electron transport chain, cytochrome C oxidase. Normally it takes oxygen, and oxygen grabs the electrons from cytochrome C oxidase, makes hydrogen ions that drives ATP synthase. And this continues until the cell is sick, stressed, until the tissues are hypoxic, and then something goes wrong. Mitochondria start to make a molecule called nitric oxide, and it blocks consumption of oxygen. Nitric oxide competes with oxygen. It blocks cytochrome C oxidase. So oxygen is unable to get in, and that causes problems. It means we don't make hydrogen ions that drive ATP synthase. We lose ATP, but also we get a buildup of reactive oxygen species that leak out of the mitochondria into the cell, start the processes of inflammation and cell death, and triggering the genetic weaknesses. So for Alzheimer's or Parkinson's or something. But when we put photobiomodulation in, it flushes nitric oxide out of cytochrome C oxidase. The cause of all the reactive oxygen species goes away. Now oxygen can get back in, electrons flow, hydrogen ions, proton gradient, ATP again. So it restores homeostasis in the cell, in the mitochondria. There are more mechanisms we don't have time to deal with. Here we have it in a bigger context: nitric oxide under stress, causing ROS. Too much for too long causes translocation of gene transcription factor, NF-kappa B, to translocate to the nucleus and trigger all the cytokines associated with inflammation and cell death. When we put light into patients, it releases the nitric oxide. The cause of ROS goes away. We make more energy, ATP. We get a reset of NF-kappa B, so that stops all those cytokines. The ATP then gets converted to cyclic AMP, which helps do the reset of NF-kappa B and triggers gene expression associated with tissue repair and cell survival. There's a lot of other factors to explain as well. The simple version of my story is this: when we're sick, when we're injured, when we're stressed, when we're old, when we have hypoxic tissues, our cells tend to be low on energy, ATP, they tend to be high in oxidative stress, and photobiomodulation, the photons absorbed in cytochrome C oxidase, tips the balance in favor of more energy, ATP, less oxidative stress. And under these circumstances, patients will heal more quickly. And we have a list of all the biomarkers that are behind this explanation. Unfortunately, we don't have time to talk about the downstream effects of this on all the cells and how it affects tissue repair, edema, inflammation, and pain. There are also effects on healthy people. We can switch on prophylactic effects, defensive mechanisms that mean when people do exercise, they don't suffer from delayed onset muscle soreness. We can do this on cancer patients to help in advance to prevent them from getting oral mucositis, or to reduce the severity anyway, and to help to reduce the severity of radiation dermatitis as well. There is a dose response. Not enough light, there's no effect. A bit more light, we can have improved stimulation of regenerative effects and anti-inflammatory effects. But if we put too much light in, then we lose the effect. And if we put even more light in, we have the bad effect. We can slow things down, inhibitory. So there is a therapeutic window, but we don't have time to talk about the details of that today. There is also a slightly different story for the analgesic mechanism. That is a deliberate overtreatment of nerves. High-dose treatments suppress C fibers and A deltas. Oops, spelling. That should be the letter C and A delta. I hope that was, anyway, an error. So here's an example, an experiment on a rat here. They can inject turpentine. This is like a spirit, a thinners for paint. I don't know if you use the word turpentine in Portuguese, but putting turpentine in the paw of the rat is painful. And then they attach this other end of the saphenous nerve to an oscilloscope to read the neuronal discharge, and then they're going to switch on a laser beam. So over a period of 1 minute, in goes the turpentine, out says the rat. This is the neuronal discharge. They switch on the laser beam and instant analgesia. Photobiomodulation can reduce or suppress nerves. It reduces peripheral nociceptive input. It inhibits fast axonal flow and reduces amplitude in C fibers and A delta fibers. These effects go back to the spinal cord, and it reduces the underlying cause of central sensitization, facilitation, and wind-up. It also, because we release nitric oxide, has an effect on blood flow. And this experiment here shows that when you put photobiomodulation on the wrist of the hand, that it increases blood flow like this. So blood flow is also important for health and healing. There's still so much more to learn. I've just said these 2 lines here. There's a lot more to go. I will give you little examples of tissue healing. This gentleman, he is a diabetic patient. He's had a hernia operation, and a year later, his wound has not healed. He gets some LED light treatment, and then 2 months later, his wound is healing well now. So it's nice to demonstrate cases of real patients, and then show evidence from randomized controlled clinical trials looking at healing rates compared with placebo controls and granulation tissue here for diabetic patients, but also Venous ulcers and pressure sores and other hard to heal wounds respond well. Burns, if you get them when they're acute. Here looking at wound area reduction over just 15 days, non-healing diabetic wounds. This is the wound area reduction. The greatest effect is with photobiomodulation and not the control. So skin, bone is another thing that responds well. This is a fracture here that's not healed after 6 months. Gets photobiomodulation treatment. Now there's good signs of union. And there's a randomized controlled clinical trial looking at grip strength. These are fractures from the wrist and in the hand here. The greater grip strength in the photobiomodulation group for the hand and for the finger compared with placebo controls. And then 2-week follow-up showing the differences have been maintained or improved. Also nerves, so this is motor function I'm going to show you. These are soldiers who have gunshot wounds. They have damage to their, they have incomplete peripheral nerves, brachial plexus injuries. These injuries are 6 months or more old. They get a long course of photobiomodulation. This is like every day for 3 weeks for 21 sessions in total. Placebo group, no change, but photobiomodulation group, an improvement in motor function. And even more to learn. Inflammation. So I want to demonstrate something in humans. We have lots of evidence from small animal studies, but this is interesting. It's a human study. Patients with an Achilles tendinopathy are given exercises to do, not therapeutic exercises. This is not to make the patient better. The exercises are to make the tendinopathy feel worse. It is an activated Achilles tendinitis, so it becomes more inflamed. And they put a catheter into the Achilles tendon sheath. They want to do a microdialysis measurement for PGE2 concentrations, prostaglandin E2. And then they're going to give a laser or a placebo treatment. So at this moment here, they have finished exercises and they have the catheter in and they take a measurement and then they give a laser or a placebo treatment. And they measure every 15 minutes. And after about 1 hour, on the placebo group, the inflammation goes up. This is caused by the exercises they did. But in the photobiomodulation group, the inflammation comes down. So this is objective evidence in humans that photobiomodulation is highly anti-inflammatory. And notice it goes up before it goes down. Sometimes people feel worse after a treatment. And I will mention that again later on in this presentation. There are many great systematic reviews on photobiomodulation. This one is in knee osteoarthritis, 22 randomized controlled clinical trials, 1,063 participants in clinical trials. And at the end of the studies, the mean result was 18.7 millimeters of pain relief on the visual analog scale. But in the follow-up period, the pain relief improves to 23.2. Photobiomodulation starts a healing cascade. And in other studies, it's been showed that photobiomodulation in knee osteoarthritis will improve cartilage production. And so after the treatment has finished, in the follow-up period, the pain relief improves. And then there's a magical moment between 2 and 4 weeks where the benefit goes up to 31.9 millimeters of pain relief. And when you compare that with non-steroidal anti-inflammatory drugs that will give 7 to 14 millimeters of pain relief, this is a very big effect. And it's non-toxic. There are no known side effects from this treatment. Edema is something else that responds to photobiomodulation. Football players with a second-degree ankle sprain put their foot in a foot volumeter here, and they measure the displaced amount of water to measure the size of the limb, and then they get randomized to 3 groups: rest, ice, compression, elevation, so standard care therapy for edema and ankle sprains, or rest, ice, compression, elevation with a placebo laser or with a real laser, active photobiomodulation laser. They get treated twice a day for 3 days, and you can see the greatest reduction in limb volume is in the photobiomodulation group. It stimulates the lymphatic system to take away edema. And there's this analgesic mechanism I mentioned. I'm going to talk about post-hepatic neuralgia, one of the worst kind of pains patients can get. If it's around the thorax, typically around here, then people can't wear shirts and they cannot lie down. They can't bear to be touched. It drives many people to suicide. So, oh, this is not PHN. This is postoperative pain. Sorry, wrong study. There's another one coming. Don't worry. Yes, this is postoperative pain. This is an open cholecystectomy, gallbladder removal. They have one laser treatment immediately postoperatively or placebo. This is measuring the amount of coproximal, it's opioids, and acetaminophen combined. And in the photobiomodulation group, they're taking less and less opioids, but in the placebo group, they take more and more and more opioids. So photobiomodulation reduces the use of opioids post-operatively. Here's another one. After one treatment, just one treatment immediately post-operatively is the best time, the best effects. Is if you can treat within minutes, it's much better than waiting hours, and it's better than waiting days. If you can treat immediately post-operatively, the first treatment is the most important. Here's another one looking at tibial fractures here, showing reduced use of opioids. And then we've seen the same results in reduced use of opioids in cancer patients receiving high-dose chemotherapy or radiotherapy as well. So, and then myofascial pain. So myofascial trigger points. Most of neck pain is really myofascial trigger points. And there's a fantastic review in The Lancet. The Lancet is the world's leading journal for breakthrough medicine. 16 randomized controlled clinical trials, 820 patients in all. PBM reduced pain intensity, reduced disability, and reduced recurrence of chronic non-specific neck pain. The results are instant. This patient has had this whiplash for 10 years. She's unable to fully rotate her head. She does better to her left. That's okay. I ask her to put her chin down, to flex and extend her head. So I want you to remember this. And then I treat trigger points. I treat around trapezius and sternocleidomastoid and scalenes. Treat for about 30 seconds per point, maybe do about 10 points on her neck. Then I ask her to stand up and we do the test again to see what has changed. And the results are immediate. She can turn more to her right. And then I flex and extend her head again, a little bit more down, and a lot more putting her head back. This is why it is in The Lancet. The effects are immediate. This patient has a scoliosis. She's been felt restricted for most of her adult life. Ask her to side bend as well. And then again, treat myofascial trigger points as well as also midline down the cervical spine as well. And the results are instant. She is very surprised. Yes, it works. As I was saying before by accident, I got the studies mixed up. Post-hepatic neuralgia is one of the worst kinds of pain, typically around the thorax. People can't wear shirts, they can't lie down, they can't bear to be touched. It drives some people to suicide. In this study here, it's a crossover study. So group A is going to get one treatment a week for 4 weeks. I didn't think that was enough, but it worked. Group B gets a placebo treatment. And then because it's a crossover trial, group B then get the active treatment 1 time a week for 4 weeks. This group remains on a placebo treatment. 19 patients out of 20, it's a small study. That's 95% of patients discontinued all medication for one of the worst kinds of pain that people can get. Just one patient, 5%, required reduced dosage at the end of the study. At 6-month follow-up, 80% of patients have maintained their reduction in pain. 2 patients returned to a pain score of 4, not requiring medication, and 2 patients returned to pain scores of 6 and 8. Not bad for one of the worst kinds of pain that people can get. What about effects on healthy people? There's an experiment here. It's done in Brazil. Going to do exercise on a Biodex machine. They're going to do lots of bicep curls on him. So these volunteers are then going to get ice therapy, cryotherapy on the bicep, or photobiomodulation, or combination of both, ice, then photobiomodulation, or photobiomodulation, then ice, or a placebo treatment. And they're going to do some blood tests before, afterwards, 1 hour afterwards, 1 day afterwards, 2 days afterwards, and 3 days afterwards. They're going to do a blood test. So this is before, this is before, after, 1 hour, 1 day, 2 days, 3 days. And they're going to measure creatine kinase, which is a marker for muscle damage. And the photobiomodulation group are pretty close down to baseline, having done the exercise and had photobiomodulation. The placebo group is up here. The cryotherapy group also goes up. And by day 3, the cryotherapy is working after 1 cryotherapy. Cryotherapy and photobiomodulation did not do quite so well as photobiomodulation alone. Delayed onset muscle soreness, pain on the visual analog scale when doing the exercises. All the groups that had photobiomodulation have got reduced pain, and it's statistically significant compared with placebo and cryotherapy. And then looking at strength, maximum voluntary capacity, torque in Newton meters here. And you can see the placebo group and down here and the cryotherapy group, but the photobiomodulation group are back to full strength. And this is partly due to blood flow, as I mentioned earlier on. So we get blood flow in healthy people as well. So I just wanted you to see at least one example of what happens on healthy people. Safety contraindications and side effects. So do not stick laser beams in people's eyes. Do not treat a tumor. There is no evidence of harm on treating tumors in humans, but we don't have enough safety data, so we'd say do not treat over that. Certainly do not treat cancer. PBM is not a treatment for cancer. It's not a cure for cancer. But there is evidence from a long-term follow-up study, 108 patients followed for 8 years, had an improvement in progression-free survival in the active photobiomodulation group compared with the placebo controls, and it was statistically significant. This is very interesting news. Many other studies have shown that photobiomodulation does not increase rate of growth of a tumor in cancer patients receiving chemotherapy and radiotherapy, but also most of the studies avoid treating over the tumor as well. Don't treat over developing fetus. There's no evidence of harm in humans, but again, we don't want to, if the mother has a miscarriage or she's unhappy with her baby, then you do not want to be blamed, so do not treat over a developing fetus. Flashing lights. Some epileptic patients have photosensitive epilepsy. Flashing lights will trigger a seizure. So make sure you do not use any pulsing feature with visible light from photobiomodulation lasers or LEDs. If you do a high-intensity analgesic treatment over a tattoo or very dark skin or over dark hair as well, sometimes treating up in the neck here, around the hair, you get a hot, prickly feeling, very unpleasant and painful. So be careful. Sometimes you have to if you're using a laser, you have to take it away from the skin. So if you use, instead of doing this, you have to maybe take it away, keep some distance. It allows the beams to diverge a bit and become less intense. So like I say, tattoos, definitely a problem. Sometimes if it's a very dark black skin, and also typically over dark hair, if you take it away from the skin, then the beam diverges and it becomes less intense and no more pain. And some people feel worse before they feel better. As I said previously, sometimes inflammation goes up before it comes down. For some hours, that's all, not for days. So yes, they have a treatment reaction maybe soon after they finish their treatment, and probably only after the first treatment you give does that happen. After that, it doesn't happen again. Normally, this is only in musculoskeletal pain, muscle and joint pain. Not for oral mucositis, it's no problem. Some neuropathic conditions maybe feel worse the first time you give photobiomodulation, but it's temporary. only for hours. It doesn't last for days. There's a lot to teach about photobiomodulation parameters, which wavelengths penetrate the best and have the best effects. Power divided by the area gives you the intensity of the light, called irradiance. So you have to understand these relationships. And then we talk about pulses, sometimes have some extra effects as well. Treatment time, not enough time, no effect, too long, you can maybe lose the effect. And then dose is usually reported in energy or in fluence. This is energy per centimeter squared. We do not have enough time to teach that today. And remember, there is a dose response, as I said before. So we want to end up here rather than down here. But here is where we get the analgesic mechanism, by the way, when we treat over nerves. So some examples in dentistry. There's a long list of things that potentially could respond well to photobiomodulation, for which we have some evidence. There's lots of randomized controlled clinical trials you can get evidence from. Here, this is treating dentine hypersensitivity. So they are looking at tactile and thermal responses here, and the results are instant for dentine hypersensitivity. In this study from Barcelona Dental School, they are sustained for the duration of the study for 2 months. So this is remarkable. So 200 milliwatt laser for 1 minute had this effect on treating on the margin of the tooth between the gums and the tooth. So the gingival tissue on the margin of the gingival tissue and the tooth. One treatment. It is the simplest possible thing you can do. But on the other end of the scale, another difficult thing, burning mouth syndrome, takes a lot of treatments. It's very slow progress. You need at least 10 treatments. I mean, this study here showing, again, they're using 8-10 nanometer laser. I think this is Barcelona Dental School again, maybe. Yes, using it for 10 seconds. Oh, I don't know if that was enough. I think they should have done more. But the report, the energy in joules and the joules per centimeter squared, just using it out of contact, it says here. So they're holding it away from the gingival tissues. I imagine it's painful for these patients, so they want to hold it at a distance. But here, looking at the pain coming down over 10 weeks there, with 1 month follow-up and 4 months follow-up for a very difficult condition to treat. Here, looking at temporomandibular joint dysfunction. These patients have had TMJ pain for a minimum of 6 months. They've been through standard care. They've had dental orthotics, the splints, and they've had medication. If they fail to respond to standard care, they get enrolled into this study, randomized to 2 groups, and they get 5 treatments over a 2-week period. And then this data is 2-week follow-up data, and you see there's a significant reduction in pain in the active group. The placebo group, no significant difference. Now, one of the difficulties for if you're new to this treatment is why there's such variation in the amount of power and power density and joules. And these may be phrases you're not familiar with. That isn't time to teach you today the details, but all studies should report a full set of treatment parameters. And then in my training course, I explain these differences and what's important. And translation between one study and another is not easy, unfortunately. And you have to master this if you're going to teach it, unfortunately. So not enough time today, unfortunately. Here's another one. This is looking at how far can the patient open her mouth after a third molar extraction here versus PBM versus paracetamol. Here, and it shows that there seems to be some improvement in the photobiomodulation group at day 2 and day 7. So very little bit of detail on the parameters here. Here they're treating for 2 minutes. Some of them I'm being shown you 1 minute. There was a study treating for 10 seconds. Does it have to be that way? No, the people who are using different parameters, plenty of people treating for 1 minute or 30 seconds for this. Others are treating, in our study for burning mouth syndrome in London, we treated for 1 minute per point. It's a complex topic we can't rush through today, unfortunately. This is neurosensory recovery after injury to the inferior alveolar nerve. So obviously, if the tooth is extracted and gets caught in the roots of the roots of the tooth get caught in the inferior alveolar nerve. They pull the tooth and the nerve breaks. If it doesn't recover within 1 year, patients are going to be stuck with loss of paresthesia and dysthesia around their lip and chin for the rest of their lives. Here's a photobiomodulation plan, 86 seconds. It's an unusual time, 6 joules of energy. But you'll see all the powers are all different between them. I wish it was easy to say there's one simple theory for treating these people. Now, I know there's a difference. Something we can't solve today all in one go. But look at this. Brush stroke directional discrimination test. Patient closes their eyes, dentist makes some movement, brushes the cheek. The patient has to report what they feel. They get a very low score, but after 3 treatments a week for 7 weeks, 20 treatments in all, wonderful recovery of the function of the nerve. Fantastic. And you can do laser anesthesia. This is me. I'm having a second molar extracted with no anesthetic. So the tooth has already been luxated, and now there's going to be an extraction with no anesthetic. And I will show you the technique that we use now for this. I certainly, there we go. That is my tooth. So we did treatment down the inferior alveolar nerve outside of the mandible, obviously the nerve that goes down in that foramen there. And so we treat either side of the second molar here, also on the buccal nerve here, and 2 points proximal to that. It takes a lot of time. We experimented with 30 seconds. It wasn't so good. 3 minutes was much better. But 3 minutes to 3 points on both sides takes 18 minutes of laser treatment. Unfortunately, the effect lasts for about 20 minutes. The procedure lasted 1 hour. So every 20 minutes, we had to do a bit more treatment. It only did 1 minute of extra treatment to each side to restore the anesthesia. So that's something you can try. The best evidence in dentistry or oral medicine is around oral mucositis, the side effect from high-dose chemotherapy or radiotherapy. This is after hematopoietic stem cell transplantation. These are the 5 grades of oral mucositis. You can see grade 4, the greatest number of patients have grade 4 in the placebo group. Only 1 patient with photobiomodulation has grade 4. None of the photobiomodulation group have grade 3. They are in the low grades, grade 2, 1, or none at all. Photobiomodulation has shifted the treatment, the patients to the low grades of oral mucositis. And in head and neck cancer patients, these are pain scores in the placebo group, pain scores in the active treatment group. Photobiomodulation is reducing the inflammation, reducing the ulceration, improving the amount of their ability to eat and drink, and therefore have better health outcomes because of that. And I can show you the protocol that we used in the United States at UPMC, University of Pittsburgh Medical Center here. We do extra oral treatments. We use this thing and we will treat through the cheeks. I don't think so. I don't know if you can see some of that. You can see some of the light coming through my cheek. And of course, we did, and we have, of course, intraoral lasers as well, so you can treat inside the mouth. And so they use this technique, and they had a reduction in the incidence of grade 3 oral mucositis or 4. So it was 40% before they had photobiomodulation. Now they use photobiomodulation. Grade 3 or 4 is reduced to 10% of head and neck cancer patients at their center there. Good. And now they use a lollipop, which treats the whole oral cavity in just 1 minute. And one more thing, in case you didn't know, we also can treat the entire body all at once at the same time. Anyway, that's all, folks. Looks like I did it on time. Any questions?
Fantastic, James. Fantastic.
Oh, can you hear that? What a fantastic noise. They're cheering. Oh, well, there you go. So.
Excellent. Well, James, we have a lot of good comments and positive incomes coming in. And I'm going to start with the following question. Can you comment on ongoing efforts to create international curriculums for photobiomodulation teaching in medicine or dentistry?
So make sure I understand the question. Are there international curriculums, did you say?
Yes, if there are any international groups, universities working together to establish a unified curriculum, for example.
I don't know if they're getting unified or not. We get fix that. I don't know if they're unified in any way, but there certainly are universities. So in France, they are now teaching in oncologists about photobiomodulation for cancer therapy side effects like oral mucositis. And at Shepherd University, which is a nursing school, we're teaching photobiomodulation there. So, and the only thing in common they have is that I'm teaching there, and some of it's my curriculum. I wouldn't say that there's any international collaboration on that. Just coincidence that I'm involved. And maybe I know that there's a dental school that teaches undergraduates at Midwestern University in Phoenix, Arizona, United States as well. But then they all use my protocols. So I'm not aware that there's any central independent body that are writing a protocol for this. So some universities, but not a global effort at this point.
Okay, I see. Great. Next question would be, where can health professionals find advanced courses in photobiomodulation, including clinical training? I mean, what are the pathways for photobiomodulation qualifications in the current days? And if you see in the future photobiomodulation or light schools?
I think we might do. There are independent classes, but if you want proper university accredited courses, then there's very little choice. I think Russie Gustave, I think is the name of the university in France for people in oncology. That could be dentists or medicine or oncologists. So that's a postgraduate course. And the nursing school, they're teaching undergraduates. That's not open for other people. And same with Midwestern. And so you really, I don't, and obviously we can't travel much because of COVID, but the possibility to learn online maybe with the Paris course. I know they have ambitions to make that widely available for postgraduate training. Otherwise, the world isn't ready yet. You can use Google and search for photobiomodulation training, and then you find manufacturers like ourselves who might offer training courses. But for accredited courses from universities, I think the only one that's available for anybody with the correct degree, correct medical degree, or dentistry maybe, is in France.
Excellent. Can you talk a little bit more about your online courses portfolio, please?
Did you say online courses? Did you say portfolio?
Yes, that's it.
Yeah. So, what to say about it? I mean, I mentioned that we have the matrix that I talked about to teach, and so I don't know if you're asking me to comment on that, but this knowledge matrix, yeah, it takes 8 hours and it's a very full day. So yes, introduction, what is it? Where has it come from? I love talking about that because it's serendipity, luck. It was an accidental discovery about it, and where we are in terms of evidence, but where we are in terms of regulations as well, regulatory approval, and where governments are in terms of endorsing photobiomodulation treatments and guidelines. That's useful to know. And where do we think it's going now? I think really more central nervous system disorders, the macular degeneration, the brain, the spinal cord. We're treating to release, we put light into bone marrow, it releases stem cells, and the stem cells circulate around the bloodstream, and they have interesting effects as well. So the future is very exciting. I go more slowly and more carefully to talk about the primary, secondary, tertiary, quaternary effects of light, the cascade of events that occur after light's absorbed in a cell. And then more details on randomized controlled clinical trials, the different kinds of wound healing, bone healing, nerve healing, that kind of thing, the anti-inflammatory effects, edema. We'll go for more evidence on analgesia, more neuropathies and neuropathic pain, and more details on what it does to healthy people. And of course, we spend a lot more time talking about understanding what photons are, what wavelength is, lasers and LEDs, and why it's different from sunlight, and how light propagates through tissue, light penetration in tissue. And then dose, of course, we have to understand why the wavelengths can have different effects, certainly on penetration. And then dosimetry, understanding watts, milliwatts, beam area, power density, irradiance, joules and joules per centimeter squared, pulses and treatment times, and how often to treat patients as well. Treatment methods, where to aim the light. We don't just treat the pathology. Sometimes it's good to treat the lymphatic system as well. I talked about treating cervical lymph nodes and preauricular lymph nodes and submental lymph nodes to help drain the head and neck region, but of course, inguinal lymph nodes for my leg, or axillary lymph nodes for my arm. Treat the lymphatic system as well to help drain the area. Treat nerves for analgesic mechanisms. Myofascial trigger points are a common component of musculoskeletal pain, so we talk about those too, and a bit more about safety and contraindications, regulations in different places, and reimbursement, getting paid by insurance companies. I don't know how the system works in Brazil, but this is what we cover in our course, and plenty more opportunity for questions and answers.
This is awesome. Great. There's a question coming from our audience on YouTube. And his colleague is asking if you could share your views on intravascular laser irradiation of blood.
Yeah, I'm convinced it definitely helps. When we treat the whole body in our system, we are effectively treating the blood. So there's some profound anti-inflammatory effects from treating the blood, so increased blood flow and reduced inflammation in the area. Possibly some other effects that need better evidence for some of the claims, but the evidence seems to be that it works. Now, does it work as well as treating a disease directly? I'm not sure. Would you rather have intravenous photobiomodulation for your oral mucositis or intraoral treatment? I think intraoral will be better, but there are parts of the body which we cannot reach with light. Light can only go 2 or 3 centimeters deep in the body, and if you want to get to the viscera, the organs in the abdomen here, and other deep and difficult to locate areas, then I think that intravascular laser treatment or the whole body NovaThor treatment, getting light into the blood, is a good solution.
Okay, another question coming from YouTube is asking if you could comment on these new technologies that are putting in the same device red and infrared sources of light.
In theory, it should work better, and there are some cell studies that show that it does work better, but we definitely need more evidence for mixed wavelengths. I believe it's good. There's a little bit of evidence to support it. There could and there should be more, because near-infrared light penetrates deeper than the red light. So commonly it's red and near-infrared light are mixed. Now, I don't know why people add blue and green light, because the light doesn't penetrate. So certainly red and near-infrared looks like it should have a synergistic effect. I'm not sure about green light and blue light as well, but otherwise you're just making daylight, because daylight is all the different colors of the rainbow all at once at the same time. Why don't we just stand in the sun and have the same effect if you're going to put lots of colors in there? That's my rationale for it. Everything needs evidence and needs supported by evidence, comparing single wavelengths with 2 other wavelengths, maybe, but if you go full spectrum, well, it would be interesting to see. I mean, these devices still seem to do something. I don't know what's optimum. I don't know. We always want more data, don't we?
Yes, for sure. Yeah, good. Some people are asking about what would be the next step to optimize photobiomodulation protocols aiming to prevent or treat hyposalivation in cancer patients, in elderly patients, and even in Sjogren's syndrome patients.
Sjogren's, yes. So, so what are the next steps? I mean, so I'm involved with New York University, and we work on University of Pennsylvania, and we're doing systematic reviews with meta-analyses or subgroup analysis of the dose response for oral mucositis. So we have a lot of data, a lot of trials to pull from. We have 47 randomized controlled clinical trials to look at. And unfortunately, the data is one of the problems is that doctors and dentists and therapists are not very good at evaluating the laser beam and doing measurements to verify it's doing what they say. The beams are usually very small, but the pathologies are quite large. And there isn't a very good systematic approach to how much light and how it's distributed across the pathology. That's one problem. A lot of people tend to copy each other using similar parameters, but we don't have anybody that does titration of dose, trying maybe 1 joule per centimeter squared, and then comparing that with 2, comparing that with 4, comparing that with 10, in a systematic way where all the other parameters are the same. So if you're asking questions about dose and treating and trying to come up with optimum, looking at the data is probably not going to teach you very much until scientists do carefully titrated dosing systems. So we make our best guesses from the non-systematic collection of doses that we see in the literature, and we make our best guess of where we can see where with New York University we can see that for oral mucositis the best study ever was treating 165 points inside the mouth for 16.7 seconds with a red laser, and it took 45 minutes to do that treatment with one beam inside the mouth in lots of different places. So we're looking at the effect size. It's the number of patients who had the biggest effect from between the placebo and the active group. So we could tell the bigger effect size, and we could see what the best treatment plan was. For xerostomia, you did say xerostomia, didn't you?
Yes, that's it.
There isn't much data. There isn't enough data to do that kind of analysis that we've done for oral mucositis. We'd like to see systematic titration of dose would be useful to try and verify that. And I have a full-time a clinical trial assistant who helps people design clinical trials so that they can come out with useful information for doctors and therapists to get the best possible results. I doubt we have enough data with xerostomia to know for sure what's best yet.
Mm-hmm. Great, good. So what about photobiomodulation protocols to COVID-19 patients? Can you comment on interesting clinical approaches in this sense?
Yes, there's a lot of potential in theory. Let me show you something that I've got. Another slide here. Number 1 there. And get down to the bottom here. Oops. That's not that far. It's a bit further up. So let's open that. There are many possibilities. It ought to be able to help the innate immunity. Now, there's just one study, and unfortunately, it's only on mice. And it shows that when you put laser light into bone marrow, it releases more neutrophils, which will be what goes after a virus. So, and they showed it in a study that wasn't to do with the virus. So this is very weak evidence. It's an animal. It's not a virus. It's a fungal infection. But it does show that it releases these neutrophils, and they will have an improved effect on reducing the fungal infection that they inoculated a mouse with. So maybe it helps innate immunity with more neutrophils for that. Then there's a matter of severity of COVID-19 symptoms. we obviously, our main concern is about patients who become critically ill and develop acute respiratory distress syndrome and ARDS and multiple organ failure due to this cytokine storm that happens. There is good evidence that PBM should reduce that, and I have a few notes on some slides about that. And I think that's probably its most potential. Excuse me, let's do that again. Where is the slide gone? I've lost my place now. Oh yes, here it is. There, 1 in 8 minutes. Yes, severity of COVID symptoms. So what we do know, oops, sorry, overclicked, too many clicks. Right. The leading cause of death from COVID-19 are acute respiratory distress syndrome and multiple organ failure. What we know is that critically ill COVID patients have high levels of particularly of a lot of cytokines, but particularly IL-6, C-reactive protein, TNF-alpha, and also IL-10. This isn't supposed to be an anti-inflammatory cytokine, and PBM seems to reduce them in all sorts of diseases and injuries, not necessarily COVID. There's no good studies on COVID patients, but in other diseases and injuries, it seems to reduce these, and it increases IL-10, which is an anti-inflammatory cytokine. So it ought to help COVID patients. There is evidence for photobiomodulation treatment of acute respiratory distress syndrome in mice, and it works well. There is some evidence on COPD on humans. There's evidence of it's reducing pneumonia in humans, but only in case series papers. So some good clues that point towards PBM ought to be good for COVID patients. And then as for patients in ICU, so intensive care, this is an experiment done on rats where they've been given an injury by overinflating the lungs, causing an acute injury, inflammation in the lungs. And these cytokines here, which are normally associated with ARDS and including COVID patients, higher levels of IL-1 beta, IL-6, TNF-alpha, are all reduced after photobiomodulation. You can see a little bit of pink there. That is PBM has almost completely erased IL-1 beta and substantially reduced IL-6 and TNF-alpha as well in the lungs of these rats. Reduce this chemotractant as well, and it has increased IL-10, the anti-inflammatory cytokine. Everything's looking good in a small animal study. Really could be useful for COVID patients. This isn't a COVID model, but this is a lung injury, and this is one of the main causes of death in COVID patients. So maybe it should work for them. So there's tantalizing little bits of evidence for photobiomodulation. Oh, I can see the arrows coming now. Yes, the arrows showing this bit down there. Right. Mm-hmm. And also lots of evidence in athletes for recovery. So all the oxidative stress from over-exercise, maybe the oxidative stress associated with COVID patients, post-COVID, maybe to help them recover as well. So we know that PBM has all these anti-inflammatory effects, and it stimulates regenerative effects through TGF-beta and regulatory T cells as well. And recovery exercise is very well documented. Maybe it'll work for ARDS. Maybe it'll reduce the long COVID, as they call it, or long haulers, as they call it in the United States. And then also with vaccination, there's some evidence when you apply photobiomodulation to the skin and vaccine is administered at the site of the photobiomodulation, there's increased antigen uptake. Now, this is not a COVID study, so I don't know what virus it was they used in this. Accelerated motility of antigen-presenting cells and improved transport to the draining lymph nodes. So they say that PBM augments humoral and cell-mediated immune responses. So this is another possibility. It could be used along with a vaccine. And there is one more thing. There is evidence. A case report published, a 57-year-old African-American man with severe COVID had 4 treatments, one each day for 4 days. and the patient had an improvement in their oxygen saturation and reduced requirement for supplementary oxygen as well. It was at 2 to 4 liters per minute, it was reduced to 1. And there were some x-rays as well. So that's the treatment, let's say x-rays. Looking at the black spaces less after treatment than before. So the score here, the radiographic assessment of lung edema, is 8 before a course of PBM, and after 4 days, it's down to 5. And so they're associating with this improvement with photobiomodulation. So yes, it's possible that PBM, it seems possible. You can argue that it ought to work, and I agree. We just need somebody to fund a big study. We did go to the American government with an idea about developing a whole body treatment system, so the Biomedical Advanced Research Development Authority, so that we could put a Novothor, half a Novothor over patients. They wanted, we've got to fund a very big study to do it, and it's too expensive. So unless you have a billionaire friend who'd like to fund us to do this, I don't think it's going to happen. We would suggest you could also put things like giant laser cluster probes in there, or Novothor maybe. So anyway, just some thoughts on COVID.
That's incredible, James. Incredible. Very good. Well, talking about this specific context, some people say that photobiomodulation was initially validated in the treatment of orphan, in the management of treatment orphan diseases, such as diabetic foot, post-amputation sensitive disorders, neck pain, neuralgias, oromucositis. In this is pure pathology. I mean, you are dealing with very relevant diseases that have no standard of care. So what are the most challenging barriers to reach the mainstream clinical setting now? I mean, what are the main barriers? Okay. Are there any resistance, for example, coming from the pharmaceutical industry?
It's no, I know everybody likes to be paranoid about the pharmaceutical industry. I can't see any attempt from them to stop it. The bars, unfortunately, the regulatory process is very strict for drugs, and now it's very strict for devices as well. And if you want to make a medical claim, if it's a drug or a device, you have to have strong evidence for it, done from high quality clinical trials. Mm-hmm. And then the way that it works in the United States, and I've got this written down on a slide, seeing as you mentioned it, I can actually show you some information of what really the barriers are for photobiomodulation. Seeing as you bring it up, let's look for a word. I think that's the word I want in here. Is that the one I want? I probably made a spelling mistake in here. I should be able to find it. Let's see. That's questions from this morning. That's that thing there. Got to scroll through lots of slides. Precautions, known as regulars, care equipment, reimbursement, marketing. It's somewhere back here. I definitely have had to answer this question many times, and so I wrote some. Here we go. There we go. So what I call the path to enlightenment. So really, high quality studies are important. One of the mistakes that scientists make when they do research in this field is they do not understand what the real regulatory pathway is. And there's some wonderful clinical trials on oromucositis, but if you don't collaborate in the United States with FDA or with the National Institute of Health in the United Kingdom, before you do the clinical trial, tell them what you're planning to do. They will give you feedback and say, we don't like this primary outcome measure. We do not like this method of diagnosis. We don't think your trial is homogeneous enough. I don't think you've got statistical power. And they will tell you all the things they think is wrong with your trial. And then you go and adjust your trial protocol. So you collaborate in advance with the regulatory authorities. This is what most scientists don't realize. They do wonderful work, and then it's not acceptable to the regulatory authorities. Also, the regulatory authorities do not approve a therapy. They approve a product. So this is a product. They will, if we use this in a clinical trial and we show that this product treats oral mucositis successfully, and we collaborate with the FDA or National Institute of Health in the UK, Care Excellence rather, then they will approve this product. They don't approve the therapy for everybody. They approve this product because this is the one that did the trial, and that gets approved for one medical claim. So they don't approve therapies, they approve products. And nobody has yet gone to FDA with a product with a good trial that was pre-arranged with the FDA. We're doing this now, so don't worry, we're going to fix this. But when you do that, then, and you get it right, they will give the product a label, an intended use label, as they call it. And then once you've got that, you need health economic data to convince the American healthcare insurance companies, or even our British National Health Service wants to see health economic data. So you must do that with your clinical trial as well. That's how you get what's called reimbursement. That's how the American medical health insurance companies will pay the hospitals for the treatment. In the UK, we have a National Health Service, it's free, but there is money that moves around in the background. The patients don't pay money, but the hospitals have money that moves around the health system. Then you get a code for reimbursement. You'll get a code for the technology that matches a code, an ICD-10 code you're hopefully familiar with. And then the other thing you really need is it has to get into clinical care guidelines. So in the UK, we have got the clinical care guidelines. We have found reimbursement. We have got the health economic data. It is going to be used. And by the end of this year, the National Health Service, with the work we're doing with them, should actually have this as, well, will there be standard care by the end of this year? I'm not sure, but the care guidelines for the National Institute for Health and Care Excellence now recommend a photobiomodulation treatment. I think the last thing we need is it needs to be taught in medical schools. These are normal steps that every drug has to go through, and nobody in photobiomodulation has done this yet. That's the problem. Nobody's stopping us. There's no drug companies in my way, but we're doing it now. So we will get there. We'll do that for oral mucositis. We'll do it for xerostomia. We'll do it for dysphagia. We'll do it for dysgeusia. We'll do it for lymphedema. We'll do it for neck pain. We'll do it for back pain. In fact, you know my goals? You've heard my goals. My goal is to have this therapy established as a first-line medical treatment for 100 different diseases in 100 different countries by the time I'm 100 years old. My short-term goal is 3 diseases, 4 countries, 5 years, and the 3 diseases are going to be oral mucositis, dry, age-related macular degeneration. Those 2 are going very well. Was working on the opioid crisis. COVID got in the way. We're going back to the opioid crisis now. We're also taking a close look at fibromyalgia, and those could be the 3 diseases: oral mucositis, macular degeneration, either fibromyalgia or as a treatment for opioid use disorder, something like that.
It's impressive, James. Well, I know you for more than 5 years now, and you never seem to get older. So I'm sure you're going to reach your goals, and we are very lucky to have you here. Thank you very much, James. People are asking if you are sleeping in one of your bed light double doors.
Yes, I have one at home, so I'm lucky.
Good. All right. Do you have any other points you would like to emphasize before we finish, James?
I'd like to speak forever, but no, my wife is waiting for me so we can have lunch, so I'm going to go home. But you can invite me back. I'll do anything you like.
Fantastic. Fantastic. Thank you very much for joining us today, James. You're quite inspiring, and I appreciate having you, your constant support in Brazil, and I hope to meet you in the near future, James. Thanks a lot. I appreciate it.
Thanks, Adam. Bye for now.
Bye. See you.
Bye-bye.
I just wanted to thank all of the members of our IT, Michael Cavallari, Felipe, Marcos, for helping us today. Also, thanks to Professor Karina Ruiz and Professor Pablo Vargas from our graduation courses for supporting our meeting today. And I hope to see you all soon. Stay safe, stay well. Thanks a lot. Bye.